My name is Tomás Reyes del Castillo. I'm glad to present to you our work, Silicone-based PTCD simulator. Learning how to perform a PTCD is challenging for interventional radiology trainees. Normally, this procedure is taught through the apprenticeship method, meaning that the technical skills are learned during practicing on real patients. This can cause several problems like longer interventional times, higher X-ray exposure, unnecessary stress for the person that is learning, and may arise some concerns over the patient risk because of the trainee inexperience. That's why we aim to develop a PTCD simulator that can be used in the setting of ultrasound and fluoroscopic guidance. For that, we created a 3D printed phantom based on a manual segmentation of a triphasic CT scan of a patient that had an enlarged biliary tree due to a tumoral compression of the pancreatic head. In this image, you can see how the biliary tree is inside of the model and it's covered by a rib cage. This rib cage was also segmented from the same CT of the patient. The biliary tree was printed with soft, flexible silicone, and we ensured that the dots were hollow for navigational purposes. In this image, you can see the distribution of the branches through the model. Then we filled out the model with gelatin hydrogel to ensure a good hepatic consistency and covered the model with a black layer of silicone to mimic the skin. The simulation was performed with 20 participants from Luzerner Kantonsspital and Kantonsspital Baden. 5 of them were interventional radiology experts, 5 were intermediate, and 10 of them were beginners. The simulation was always performed in the angio suite using radiological protection and using the real tools or materials as any standard PTCD. After the simulation was done, we gave the participants a questionnaire for a satisfaction evaluation using a 4-point Likert scale. The methodology itself of the simulation consisted in performing a normal workflow of a PTCD. The first step is always the puncture. In this image, you can see how participant is holding the model, trying to look for a nice intercostal space and advancing the Shiba needle. Then, while advancing the needle, the participant is able to see in real time the advancement of the needle and to check the localization using the C-arm. You can rotate it laterally or cranially. Also, they were asked to wait for loss of resistance. If this happened, then they were asked to do a cholangiography. The cholangiography was made with contrast media as usual. Here in this video, you can see how is the diffusion of contrast inside of the biliary tree, showing the typical anatomical appearance. If this was successful, then the cannulation was feasible with 0.18 stainless guide wire. In this video, you can see how a participant is navigating and turning the wire to get into the main hepatic duct. If the cannulation was successful, then the participants were asked to introduce an EFSET to dilatate the access site, bring a hydrophilic guide wire, and then introduce a catheter. This catheter normally was a 4 French Bernstein catheter, or alternatively, you can use a standard drainage catheter too. The experts that tested the model were also asked to perform PTCD from the left side, and we found out that it was feasible, as you can see in this image. Also, there was a possibility to do sonographic puncture for the ones that prefer this method. They could do it from the left side, from the right side. And here is an image of how is the appearance of the distal branches of the biliary tree on the left lobe using a linear transducer ultrasound. So after finishing the simulation, we found out that it was feasible to find and cannulate a biliary duct every time. And it was also feasible to complete the PTCD every time from right and left. The most interesting result that we got from the questionnaire, that was that the realism of the model was rated as excellent in 60%. The tactile feedback was also rated as excellent in 50%, and the other 50% was good, so all positive responses. The injection and diffusion of contrast and the visualization of it in the fluoroscopy was rated at excellent in 60%. And the overall simulation quality was rated as excellent in 65%. The rest of 35% was rated as good. So as a conclusion, we believe that our simulator allows a realistic first contact with the PTCD procedure. It allows the possibility to perform the complete procedure from right or left side, and is minimizing risk to the patient, but also for the trainees. The limitations were that this device were not able to simulate respiratory movement and the complex development of it. The cost was around 2,000 Swiss francs. Thanks a lot for your attention and time.